I'm doing my presentation on systemic lupus erythematosus. I don't think I pronounced that correctly, or SLE. SLE is due to the immune system attacking its own tissue through the formation of antigen-antibody complex. This is going to lead to damages in various tissues and organs and suppress normal immunity. The normal clinical characteristics of SLE are fever, weight loss, and fatigue. However, SLE also affects our various organs in our body, like the kidney, the gastrointestinal system, the skin, the joints, the brain, the heart and lung, and other hematological features. Because of that, there are various comorbidities associated with these organs, like nephritis and some gastro-digestive diseases like diarrhea, nausea, vomiting, constipation, abdominal pain or abdominal growth. And SLE is also related to skin diseases like rash, hair loss, mouth sores, and so forth. And SLE can also be associated with joint-related problems like arthritis. And because SLE affects the brain, it is also associated with our neurologic functioning through symptoms like confusion, depression, seizure, stroke, and so on. And SLE is also associated with certain diseases or illnesses that occur in our heart and lung system like pericardium, pleura, chest pain, irregular heartbeat, pleuritis, pericarditis, and so on. And SLE can also affect our hematological functioning. It can lead to reduction in white and red blood cells and platelets or lymphopenia. SLE is an example of a multifactorial disease, and because of that, we can see that the gene-environment interaction is at play in here. SLE can be due to genetic, with a kin having an autoimmune disorders. And SLE can also be due to the medication we take, like BP meds, antibiotics, or anti-seizure meds. SLE can also be due to factors in our environment, like sunlight or UV exposure, stress, trauma, or viral infection like the Epstein-Barr virus. Females have higher risk of SLE compared to males. And this is partly because of the hormone called estrogen. SLE can be prevented or treated using medications like immunosuppressive drugs, hydroxychloroquine, and corticosteroids. And there's also a need for an integrated treatment and screening with SLE and the following physical and neurocognitive comorbidities like Sjogren's syndrome, antiphospholipid syndrome, thyroiditis, hemolytic anemia, and idiopathic thrombocytopenia purpura. And screening and treatment for SLE should also be integrated with any of these comorbidities. Prevention and intervention strategies should focus on the high-risk groups like Blacks, American Indians, Alaskan Natives, Hispanics, Asians, and women of childbearing age range, those between 15 to 44. These individuals would benefit from additional support and focus by public health officials, and these individuals should be encouraged to undergo routine screening and maybe treatment. And based on the CDC website, maybe there's also a need to increase the number of physicians and health professionals in the Washtenaw and Wayne counties in Michigan, in DeKalb and Fulton counties in Georgia, in San Francisco County in California, and in New York City in Manhattan. Unaffordability can serve as a barrier to care seeking, and this can lead to delay in healthcare seeking, causing all kinds of health outcomes, including SLE. Unaffordability of care can also lead to health disparities. Because of that, efforts to expand affordability, accessibility, and effectiveness of screening and medication should focus on the high-risk groups in the slide mentioned previously, in order to minimize racial and gender-based health inequalities. It is also logical to assume that undertreated or underdiagnosis of SLE may be present in areas that are entirely or predominantly rural, areas that are highly segregated, areas that are predominantly black, or areas characterized by high income disparities. In addition, physicians are reluctant to see people with medical complexities, or those with chronicity of illnesses, and those taking multiple medications. Physicians are also less inclined to see Medicare or Medicaid patients due to reductions in payment received. Because of that, it is imperative to strengthen the healthcare and medical infrastructure to better meet the needs of these people or people living in these areas. These efforts can include making screening available in free clinics or community-based health centers, helping people defray their healthcare costs so that they can better afford screening and treatment, providing easy access to screening and treatment, and providing affordable medications and other healthcare services. It is also imperative to ensure that those who are in the high-risk groups or people living in these areas have adequate insurance coverage. These are the references I use.